Well, thank you for coming nice and early in this small, I'll call it intimate room for this presentation. And we're here this morning to talk about a collaborative model for interdisciplinary education in speech-language pathology, which is probably geared toward interprofessional education. I'm Steve Blaustein, one of the presenters, and I am a speech-language pathologist, and I am a faculty member at the Department of Speech Pathology, Speech-Language Pathology at Touro College. My co-presenter, who is here with me this morning, is Jill Horbakowicz, who is actually the chairman of the Department of Physical Therapy at Touro. And if you take a look at the other co-authors on this paper, Alexandra Lopez, who is faculty in occupational therapy, Sandra Middleton from our physician's assistant program, Rivka Malitsky, who is from occupational therapy, and Sandra Russo, who is the chair of our nursing department. So I think before we even begin taking a look at the authors and collaborators on this paper, you can see that we represent an interdisciplinary, interprofessional group and have learned a lot about interprofessionalism, which is a key term based on my work with this committee. Just to get an idea before we start, how many are educators? College or? Let me say college, university educators. Other areas of practice, public schools, or? And okay. Before I say this, I'm required to produce the mandatory disclosure statement. And I'll just summarize it. I have to name everybody individually, but I just did, to say that none of us have any relevant financial or non-financial relationships to disclose. So a little bit about who we are and where we come from. The Touro College School of Health Sciences began in 1972 with a physician's assistant program. The school now has an enrollment of approximately 1,200 students, and we comprise nursing, occupational therapy assistant, physician assistant, physical therapy, speech and language pathology, and just this year added the Department of Behavioral Sciences. If you notice, in parentheses, following our physician's assistant program, we're on 3 campuses, occupational therapy 2 campuses, and one of the unique challenges that we are faced with is we are a college system that is housed in and around the New York area. So we have if you're familiar with New York, we have campuses as far out as Bayshore on Long Island. We are in Brooklyn, we are in Manhattan. So in working collaboratively and putting together an interdisciplinary model, we have to overcome one of the barriers of getting together to just collaborate. So why is interprofessional education so important now? Why is IPE and IPP so important? I'm going to take a few minutes and just talk about some experiences and my own personal reflections as a speech pathologist. And teaching courses in a speech and hearing department in a master's program. I think we are very, very good at teaching methods. I think we teach clinical technique, and I think we strive to graduate students with the highest academic and clinical experiences. I think we do well, and while this convention has a huge thrust of interprofessional education, it reminds me of where we were when we started with evidence-based practice, where to keep current and where to keep relevant. We needed to instruct our students and our membership that evidence-based practice was the way to go. And we learned about levels of evidence. We learned about searching. We learned about internal and external evidence, the highest levels of evidence, and became proficient in becoming solid clinicians using evidence-based practice. We are now in a similar place where to remain current and relevant and accountable, we must be aware of what is happening in this country in terms of in terms of interprofessional education and interprofessional practice. We do not, in our programs, teach much about the economics of healthcare. We do not spend a lot of time and give courses in accounting, who funds our services, Medicare and Medicaid guidelines, private insurance payments, and who funds our services. We put out clinicians who assume they're going to be paid, and many of us work as employees, and the check comes every 2 weeks, but we do not understand where and how that check comes from. To be current in the current health climate, we need, as a profession, to recognize that and be part of the systems that reimburse us, and we need to show that we can add value and efficiency to healthcare. This does not only go for the people who are practicing in hospitals and agencies and nursing homes, but the changes are occurring in school systems as well. A move to RTI, response to intervention therapy, has changed models of assessment and intervention throughout our school systems. A move to more push-in type of experiences rather than pull out in the way we provide services has necessitated collaboration with educators at all levels in the school system. The use of the Common Core has changed the way we teach, provide services, and write IEPs, and must collaborate with classroom teachers. This goes as well across medical settings where we collaborate with a variety of health professionals, physicians, and anybody involved in the care of patients. In moving towards this presentation, I was struck by a number of conversations I had while I was here. I spoke to a speech pathologist who was a former student of mine yesterday, who told me that she is working for an agency and that she was invited by the school she is contracted with to attend some workshops the school was providing. The administration of the school later asked her not to attend. They said that because she would attend without pay, it would be a poor model for the rest of speech pathologists who are on staff, and felt that that would be part of their salary day and should be included in their work time. I spoke to another speech pathologist yesterday who said that she was not being allowed to attend IEP meetings because she carries 150 students on her caseload, many of them in groups, and the time that she spends at meeting is time away from being able to treat her clients. I understand that, but it also removes her from the team, is certainly not interprofessional practice and education, and does not allow for her voice to be heard as part of that interdisciplinary team. Coming down in the elevator just now, I met somebody and we had a quick chat, and she told me she was here to recruit speech-language pathologists across the country for telepractice. Contract agencies, telepractice, many of the things that we do are going to pose challenges for interprofessional collaborative practice in an era where that is the way healthcare in this country is going. So we must be cognizant as we train our students that interprofessional education, collaboration, working on a team is essential to effective practice and benefits the patients. And we will see specifically how shortly. Lastly, why is this so important now? The healthcare landscape, as well as the educational landscape, is rapidly changing. It is not a coincidence. It is not a coincidence that many of the reports I will cite prior to Jill's presentation of our model were 2011, 2012, 2015, right up to a recent revision of the IPEC core domains that were revised in 2016. These reflect the Affordable Care Act. And in 2010, when this was beginning to come into practice, what's the word I should use here? It was a reaction to the fact that literally millions of uninsured patients will be added to a healthcare system that was already stressed, where there was already a shortage of primary care providers, and where the cost of services were skyrocketing. And in addition, it was noted that the cost of healthcare in this country is the largest in the world. It is the greatest in the world. It's probably not a surprise. Represents 17% of our gross national product, and by 2020, it's estimated that it will be 20% of the gross national product. The addition of the changing landscape with the Affordable Care Act and changes in models away from fee-for-service delivery, notions of bundled reimbursements for different diagnoses, where hospitals would receive one payment for a certain type of disorder, and if they were able to treat that more efficiently, more quickly, there would be rewards and bonuses. Hospital stays are getting shorter. There is more treatment in outpatient facilities and day procedures, and the fact that we now can get vaccinations, flu shots, and pneumonia shots at CVS and Walgreens reflects the current economy and economics of where healthcare is going. For speech pathologists to be part of a system that's moving in that direction, we must realize the direction in which care in this country is going. And that is team-based, collaborative, interprofessional practice where we work together to provide health care that will, among other things, shorten patient stays, hasten recovery, add to safety, and reduce malpractice. Yes?
How do you bill Medicare for that in public school setting? We've had some issues with that in terms of if we co-treat, if we do consultations with the group. I mean, I know it's for the betterment of the child, but Medicare doesn't have a little box that says co-treat, team, players, that's not really what they're looking for in their billing.
One of the problems we have is not only is Medicare and Medicaid being billed through public school systems, but that billing becomes a problem on many different levels. And the answer to the question is it varies. Co-treats, you cannot bill two services at the same time, so one service is being billed. Time elements become an issue as we have to put in modifiers. Diagnoses are an issue, and we're struggling with it. And every school, there's no universality in the way that's being done. It's varying from school system to school system, and I think that billers and insurance coders are doing what they can until they are questioned.
And I don't want to, I really
Yeah.
don't want to talk about the Affordable Care Act, because I want to hear
Yeah.
more about it. But I do want to ask a question about university billing. I graduated from college in Stoughton,
Yes.
in case you can't tell. And I went back to my own undergraduate program a year ago, and had a wonderful tour of their clinic, which is all allied health professionals.
Right.
It's terrific. And they run a private clinic there, but they're billing insurance.
What we'll do, if I can stop you, is come back to that, and I'll talk to you afterwards, and we'll address that.
You guys do that,
We'll address that. We'll address that at the end. Okay. So, ASHA has defined interprofessional education. ASHA's definition of interprofessional education that is based on the World Health Organization definition is it's an activity that occurs when two or more professionals learn about, from, and with each other to enable effective collaboration and to improve outcomes for individuals and families we serve. And I think the key words here are about, from, and with each other to enable effective collaboration. Interprofessional practice, or IPP, is defined as when multiple service providers from different professional backgrounds provide comprehensive healthcare or educational services by working with individuals and their families, caregivers, and communities to deliver the highest quality of care across settings. Traditional speech pathology delivery models have different terms. I quote from Rhea Paul's text on clinical methods, which was published in 2016, very recently. If you speak to speech-language pathologists and you ask them and discuss about interprofessional practice, the response is, we've been doing that. We've been doing that during our career. We are on craniofacial teams. We are on teams that deliver services to children with autism. The fact is that these models do not reflect what is being viewed now as interprofessional practice and interprofessional education. Multidisciplinary, as it's referred to in our texts, is discipline-specific assessment and provision of services with minimal integration between providers. Interdisciplinary is where you have a discipline-specific assessment, some communication between providers, complementary goal development, where your providers may incorporate some elements of other goals, and transdisciplinary is where you have an ongoing dialogue, a single integrated service plan, single assessment by professionals from several disciplines. I think of these models, transdisciplinary would become closest, but is still not exactly interprofessional practice. And this is addressed in the recent ebook that I suggest everybody take a look at on the ASHA website that was edited by Alex Johnson that discusses looking at interdisciplinary versus interprofessional and realizing that while many people think we are interdisciplinary, if we are not incorporating core domains, if we are not reflective of the triple aim in healthcare, which I will shortly discuss, if we do not realize the effect on prevention, on the community's health system, on the health experience of the individual in our provision of services, it is not truly interprofessional practice. So, why interprofessional education? I think we talked about it. Number one, it is not unique to ASHA. This began with IPEC, the Interprofessional Education Collaborative. I shouldn't say it began with them, but going back to 2011, there were 6 organizations that met, of which ASHA was not one, that grew in the number of members. and ASHA is now supporting the IPEC goals. Interprofessional education is recognized globally and in the United States. I think anybody who's involved with interprofessional education and interprofessional practice supports the benefits of IPP to all stakeholders. And the research that's out there shows that interprofessional practice reduces errors, improves the quality and safety of patient care, and is economically feasible and brings down the cost of health care. So, again, looking at traditional models of delivery of service in speech pathology, looking at considering ourselves as already doing this if we're using a, quote, multidisciplinary model or an interdisciplinary model. IPP only occurs when the team members simultaneously consider the client's issues. When best alternatives are considered as a group, when we recognize the role of each professional in the group, and that when we can negotiate, approach, and consider all concerns raised by all individuals. These are the elements of interprofessional practice that must be considered. And in terms of our goals here in interprofessional education, showing models or a model that has taught our students to do this, we recognize that this must be driven by the faculty and the educators on the campuses in speech-language pathology programs, and that that must be done with the support of the administration and other disciplines and professions within colleges, as well as reaching out to community sources. Going back to as early as 2002, the Interprofessional Education Consortium, which consisted of a group of educators, evaluators, and administrators from across the United States, made some recommendations. They recommended that we prepare our professionals through interprofessional education, and that's the key here, via diverse fieldwork and education. Our goal is to embed experiences, curricula, materials, and classroom and out of classroom and community experience to provide actual interprofessional experiences reflecting the key concepts embedded within interprofessional education, and to provide the knowledge, skills, and values to collaborate effectively with others so as to serve communities and families. Lancet, 2010, and many of the organizations, and this really includes a variety of professional, advisory, government agencies, when they talk about the true interprofessional, collaborative, professional experience, talk about a vision and use the word vision. And they talk about interprofessional and transprofessional education that breaks down professional silos. And when you start to read through the literature in interprofessional education, there is a degree of repetition of key words, which I think is good, because it forces us to learn the key points, but it also shows that within professions, we are using the same terminology. We are using the same, quote, jargon that we each understand. One of the difficulties in creating an interprofessional education program is we all speak different languages, so that when professionals meet, and physical therapists and occupational therapists and physician's assistants all talk about what we do, we all have a different jargon, which breaks down communication. So that we need to break down these professional silos, enhance collaborative, and the other word that's key in here is hierarchical. That as difficult as it is to view that there exists a hierarchy within our medical systems, our school systems. It does exist on a flow chart. And certainly we are answerable and responsible to administrators and supervisors and what have you. But in provision of services and to maximize care for our patients, a hierarchy where the highest person on the ladder gets the say and may discount other recommendations or points of view that are valid and enhance care and value is not going to work in the healthcare system that we are envisioning. In May of 2011, IPIC published the core competencies for interprofessional collaborative practice to define specific competencies for interprofessional collaborative practice intended to guide health profession curriculum development. It was a document created initially from the fields of nursing, pharmacy, medicine, osteopathic medicine, dentistry, and public health. And in order to collaborate, there were previously different models of core competencies. There were different suggestions, but what happened at this conference, and this is the one you will continually read about now that has become the core basis for interprofessional practice, is that these domains were best stated as domains that could be shared by professionals. So these competency domains, which is the core of interprofessional practice, requires moving beyond profession-specific educational efforts. And I'm not saying that we eliminate them. I'm not saying we reduce them or dilute them. I'm saying we must continue to educate our professionals at the highest level of skill. This is in addition to. And the addition to is we need to think beyond our own silo, beyond our own individual goal set and linear thinking for the patient. We must engage students of different professions in interactive learning. We have to get our students at the graduate level, at least that's what we're referring to here, together to collaborate and actually experience and use these principles in practice. Having a professor from another discipline come in and give a lecture, being in a classroom with students from other disciplines while you listen to a lecture on nutrition is not interprofessional practice. It can be a small element as part of an interprofessional curriculum, but it is really not the key to establishing an interprofessional education program. One needs to learn to work effectively as members of a clinical team, which becomes a fundamental part of learning. And here they are. And you will see this many times. There were 4 domains originally identified: values and ethics for interprofessional practice, roles and responsibilities for interprofessional practice, interprofessional communication, and teams and teamwork. And you can see that these were provided in 2011. It is now 2016. These are relatively new domains and concepts that we are trying to integrate into our curriculum and must be taught and provided for our students to be effective clinicians, educators, therapists moving forward. And the key is that the competencies under each domain were general enough to allow different professional education programs to develop IPE programs to have flexibility in the design. We need that degree of creativity, flexibility and independence to teach these domains. And if we become too specific, too precise in the way we teach them, they will not work across all domains because there is variety in who we are and what we do. So we're looking at a general areas of competencies that we must instill. The research also shows that our collaborations do not have to be always with 10 people. We always do not share the same view. So whether we're working with 3 other professions or 5 other professions, these domains hold true. So the core competencies in a nutshell: mutual respect and shared values. Values and ethics is part of our ASHA Code of Ethics, our responsibility to our patients, and these are values that we share with our professionals, other professionals, and must recognize going forward that we have the best interests of our clients, patients, and students at heart. Roles and responsibility. It is critical that we know what we can do. It is critical that we know what others can do and what we can accomplish together. We must be aware of our scope of practice, and we must be able to share that information with others effectively. Interprofessional communication with health professionals and patients and families. It's not just with each other. We must share it as part of a team that includes patients, families, and all stakeholders in the equation of healthcare. And as speech-language pathologist, in terms of value added, looking at communication here, when we deal with that whole score of patients who have communication disorders, which is what we do, in terms of improving, maximizing healthcare, providing efficiency, this is the area where we can provide, it's one of the areas, a great deal of value in terms of sharing with other professionals issues such as AAC, improving intelligibility, communication devices, facilitating comprehension. So interprofessional communication here, on one level, we're talking about the sharing of ideas with our colleagues. But on our level, this is the core of our expertise and what we're teaching in our graduate programs. And lastly, teams and teamwork, relationship values and team dynamics. These are the core values and competencies that are the key to interprofessional education and interprofessional practice. If you are not infusing them into the patient care model when you are talking interprofessional practice, it is not interprofessional practice. There possibly is a lacking area. So, the domain principles, as I mentioned, are general in nature. They function as guidelines. They are not specific targeted. They are to access, share, and build upon. Health professions and the schools bear the responsibilities for the development. That's why we're here. We will provide a model that we developed, but the key is the programs, the graduate programs across the country are being called on when we talk about interprofessional education to incorporate this into our students. Core competencies will create the framework for curricula, guide learning approaches, strategies, and achieve outcomes, provide a lifelong learning continuum, prompt dialogue, integrate IP with current accreditation, strengthen scholarship through research, set accreditation standards for IPE, and inform for licensing and credentialing. And if you notice items number 6, 7, 5, some of the words in there, current accreditation, accreditation standards for IPE, licensing, credentialing, As of the 2011 conference, the IPEC conference, many of the associations there had been moving towards, but not firmed up in putting interprofessional education and interprofessional practice into their programs. Many of them have since moved beyond that, and the American Speech, Language, and Hearing Association has done that as well. So we are no longer just paying lip service to IPP. We are putting it into our programs, and starting in 2017, the CAA, the Council on Academic Accreditation, will be looking towards standards in interprofessional education being incorporated into every graduate program. It will be a requirement for receiving continued accreditation. In 2016, the Interprofessional Education Collaboration Board issued an update. What happened is there is now a greater emphasis on population health outcomes, and that there are now some major changes in the system. And a lot of this was in response to implementation of the Patient Protection and Affordable Care Act of 2010. What these changes were is increased focus on the triple aim. Core domains is a factor in interprofessional education and interprofessional practice that one needs to be aware of, and one will continue to encounter that as we move forward, as the core competencies serve as a foundation. The triple aim, and you see the graphic in the lower right-hand corner, this triple aim is a driving force in a lot of what we do in interprofessional practice, and a driving force in the Affordable Care Act. The notion is to improve healthcare across the country. 3 items receive consideration. Number 1, we must improve the patient experience of care. The patient experience of care, including quality and satisfaction, safety, outcomes, reduction in errors, improving the overall involvement and experience of the individual patient, improving the health of populations. It stands to reason that if we can improve the overall health of populations and provide a healthier individual, it will require less medical care and intervention. Where this comes into practice in terms of speech pathology is we need to start talking about prevention. And prevention must be embedded within our coursework throughout the curriculum. And lastly, the triple aim, reduce the per capita cost of healthcare. And the most noticeable change is also that the realization is the larger goal here is collaborative practice. So the overriding general guiding domain is to consider collaborative practice. And collaboration competency becomes the general domain, and within that domain, the 4 core competencies will be subdomains. And most of the wording is unchanged, and then within those core competencies, we have many, many sub-competencies that help to clarify. And competency 1, again, values and ethics. Competency 2, roles and responsibility. They're explained here. Work with individuals of other professions, climate of mutual respect, use the knowledge of one's own role and the role of other professions, communication with patients, family, communities, and professionals, and apply relationship building values and the principle of team dynamics. IPE is now a requirement of many accreditors of educational programs across the health professions. Okay, so ASHA, and to get to IPE, one has to understand that. ASHA charged in 2013 a committee, 13 members, including speech-language pathology, audiology, physical therapy, and nursing. And if you notice what they said, they charged an ad hoc committee on interprofessional education to develop specific actions that address education and core competencies of IPE, and notice the next words, for reimbursement models for students and members. So the initial drive for ASHA to bring in IPP is to charge a committee realizing the change in the healthcare landscape and bring reimbursement into the picture. In short, here is that committee's recommendations. And the recommendations were rated as high to low priority. Number one, a reimbursement model was expanded to add practice in addition to reimbursement to reflect changes in our practice. It's clear that we can't just address reimbursement models without viewing our model of intervention and delivery of service. Number two, to endorse the IPEC core competencies. Number three, an education initiative for all stakeholders, students, faculty, and practitioners, to expand ASHA IPE and IPP continuing education activities, to develop a research agenda, to develop and encourage the CAA to establish IPE standards, and to engage the CFCC of ASHA, the Council for Clinical Certification, to again bring IPE standards into the mix. If you look at ASHA's envisioned future statement, strategic objective number 2 identifies the role of interprofessional education and interprofessional collaborative practice in aligning service provision with reimbursement systems. By 2025, academic programs will be using IPE, and students and ASHA members will be engaged in what is clearly state-of-the-art effective interprofessional practice, which involves dissemination of resources to explain, collaboration with stakeholders, connect with other organizations, research standards, incorporation, evaluation. So if one wonders why this month's ASHA leader has IPE on the cover and why there is so much attention at the convention, take a look at strategic objective number 2, which is ASHA's support of the IPE and IPP momentum across the country. If you take a look at the 2017 IPE CAA standards, beginning with the new accreditations, standard 3.0B curriculum under academic and clinical education in speech-language pathology, professional practice competencies, new content, added knowledge of interprofessional education. That is a new standard. Added knowledge of interprofessional education. And it's there in many ways. Accountability. Understand the healthcare and education landscape. Integrity. Effective communication skills. Professional duty, understand the roles and importance of IP assessment and intervention, understand the roles and importance of interdisciplinary interprofessional assessment and intervention, understand one's own role and others of professions, and clinical training programs. Our graduate programs must begin to embed these principles into coursework and experience to make this happen. So what do we teach? Team building, knowledge of professions, impact of culture and communication. I think that's clear. It's clear to speech-language pathologists where we collaborate. And if we just take a quick look at some of the areas where we provide services, swallowing disorders, aphasia, dementia, neurogenic. We work with neurology, neurosurgery, medical imaging, radiology, pharmacy, physical therapy, rehabilitation. I can go on and on here. Opportunities for interprofessional collaboration and education and learning that must be embedded into our coursework. Education, teachers, psychologists, administrators, reading specialists, school nurses, child language autism, pediatric neurology, developmental pediatrics, board-certified behavior analysts, psychopharmacology, audiology, plastic, I can go on and on. So that the opportunities for interprofessional education and opportunities are immense, and the question is, how do we embed this? How do we create this? How do we teach this? So the research has shown, in summary, some of the critical elements of a program. Commitment from departments and colleges, diverse calendar agreement, curricular mapping, mentor and faculty training, a sense of community, adequate physical space, technology, and community relationships. And I think you'll see when we present the model we created that all of these elements are integrated into our programming. Some of the emerging approaches: team-based experience, shared practica, promoting generic outcomes with learning of knowledge, skills, or attitudes where IPE adds value, and designed experiences. So, what else do we need? Administrative support. We clearly had that, and we will illustrate that, and the creation of our IPE committee and program receives support from our administration on every level. You need an interprofessional programmatic infrastructure. This can't be done in isolation. A committed faculty, and a recognition of student participation, whether it be certificates, credits, acknowledgements. Students must be acknowledged for their participations in the program. There is no single way to provide interprofessional education, nor is there a single way to measure outcomes. So, if we look at some of the responses from our speech pathology students who went through the program we're about to present. I'll do this quickly and then turn it over to Jill. Did you gain knowledge from other disciplines? 96% of our 50 students stated yes, they did. 96%. Some examples: they learned nutrition can affect outcomes, intricacies of discharge planning, collaboration in hospitals and home care, the importance of social work, medication uses, side effects of medicine and pain management, and how it can affect the communication in patients. Did you improve your knowledge and skills as a clinician? 100% said yes, with overwhelmingly improved self-confidence, their comfort level, their flexibility, their collaboration, understanding their roles and responsibilities, how they viewed modifying their ideas. Did this change, did this experience, a collaborative experience, change your view as a clinician? 91% said yes. Feelings of importance, role validation, respect for professionalism. They had more knowledge than they were aware of, and they have respect for people's and their own expertise. 100% felt that interprofessional practice was critical in case management. Important to patient care, collaboration, listening, contributing, consensus building. Are you more confident as a clinician? Greater self-confidence, I can contribute, our roles are respected, validation of knowledge, 100% said use. So if we look at the Touro model that we're about to present in terms of programming, and if you look at the measures of success, we had commitment and administrative support, curriculum mapping and placement, calendar agreement, which is huge. Faculty training, coordinated planning. We had the space, we had involvement of the community and technology, and we provided the student recognition. So let's see what that program is like.
Thank you, Steve. So I want to talk to you about what we did at Touro College, because we developed interprofessional education. So some of you are educators and work in a college, and some of you are clinicians that work in the clinics, but either way, you're going to be a team. And so if we start teaching this in school, then when the students get out of school, they will be more willing to collaborate. So the way that we started this is we formed a committee, and on the committee we had somebody from each profession, and we basically just sort of talked about what is it that we want to do? How are we going to start this interprofessional education? Let's look into it. So we had our first meeting, we thought about those IPEC competencies, and we said, which ones do we want to talk about? Do we want to do teams and teamwork? Do we want to do them all? We thought about topics that might be good, because if you have a PT and an OT and a speech therapist and a PA, like, what is it that you're going to work on that everybody is going to have a role? So we had to think about those things, and we thought about, should we do a simulation? Should we have patient actors? Should we do a case study? Should we, do something out in the community where we all had to co-treat? Here were some of the things that we were worried about. So we have about, not 1,500 actually, we have like 1,200 students in our School of Health Sciences. So, how are we going to get them all in one room? Are we going to get them all in one room, or should we do something else? Where are we going to have it? What time of year are we going to have it? How much is it going to cost? What topic are we going to pick? So the first time around, we said, you know what we'll do? Let's do people in their final year, and we'll let 10 people per program. So that would have ended up with like 70 students already. We wanted a professional space outside of the classroom. We just thought that that would enhance the experience. We were lucky enough to find a common free time for almost all the programs in October. We were lucky enough that our dean found us some money to hold this program. And we talked about it, and we thought about the theme, and we thought that quality improvement, or QI, would be very relevant to everybody. So that's what we did. We had our first annual Touro Interprofessional Symposium, and we called it Healthcare Quality: How QI is Utilized by Healthcare Teams in a Variety of Settings. QI is really just looking at every step in the process and making sure that it's working. So if you had a breakdown somewhere, you could figure out where it was and make everything better. And it really should take place in all healthcare settings. So we were thinking of it like when a person transitioned from, let's say, the hospital to rehab, or rehab to home care, there's things you had to think about. So first thing, we had to come up with a patient. We sat around together and we thought about how to develop this fictitious patient. They should be realistic. It should have a role for everybody. So, I'm a physical therapist. I could give the person a broken hip, and then we could work on that, but speech would have nothing to do in that case, so we had to think about it. So we had this patient, and we wanted to put him in all of these different healthcare settings: acute care, rehab, skilled nursing facility, and home care. And here's what we came up with. We came up with a 58-year-old male who had been in a car accident and a past medical history of substance abuse. And therefore, after this car accident, he had a traumatic brain injury with frontal lobe abnormalities and dysphagia, impulse control, irritability. He did happen to break his hip. We made him a pharmaceutical salesman with this substance abuse. I know that was a little mean. He was the sole source of income for his family, and he also had to take care of his mother. And so we borrowed this small auditorium at Beth Israel, which could seat 70, and we planned this afternoon program as our first IPE. So I made up a poster which was completely lame, and then our marketing department took it and they made this beautiful poster. That's like a stock photo. And what was really funny is I was taking the subway the next day, and I saw that same stock photo on the subway, and it was like, learn how to be an X-ray technician at our college. It was the same picture, which I thought was very funny. So I'm very fond of that multicultural health professional picture. So basically the day went from like 1 to 4:30. We had 19 faculty, and we had 45 students that came. So what we did was we had the faculty come 30 minutes early, and we told them about the case, and we told them, like, here are some questions that you might want to ask when you're doing the case. We started the day with a panel. So we had a representative from PT, OT, nursing, speech, and we asked them about healthcare quality improvement. What does that mean to you? So they talked to the audience about different things. Like the nurse was talking about how they're allowed to say if the doctor has errors. There's a speak up kind of mentality in the hospital, and it makes all the patients, safer. Then we had breakout sessions. So we had these breakout groups that followed a hypothetical patient through various practice settings. So the students came into the room and we gave them the case and we were like, read this case over and then we're going to have a conversation about it. We talked for about 45 minutes and we had one person write down all the findings. So things that we asked the students, for example, would be what are the quality concerns for this patient in this setting? What is your role in optimizing that outcome? How might care be compromised? How could we avoid that? In anticipation of the transition to the next sort of setting, what could you do? So here's the first setting. Patient was admitted through the ER. They received their surgery for their total hip arthroplasty, and discharge is scheduled for tomorrow. Right now, we're concerned with the fact that the patient has pneumonia and they were found out of bed on the floor. So there's a lot that the students can talk about. In the next setting, the patient was now in inpatient rehab. So we gave them that little blurb there, and now discharge is scheduled for tomorrow from rehab. Here are the things we're worried about. The patient is not following their hip precautions. You know, they're going to dislocate their hip if they don't do what they're supposed to do. Pain management is compromised. This guy has a substance abuse problem and he's in a lot of pain, and we have to worry about those things. So you could see how possibly maybe the PAs were sort of worrying about that. Dysphagia diet, that was sort of how the speech language pathologist weighed in. Can't navigate the steps safely. In the next setting, he's now in a skilled nursing facility. Now he has a pressure ulcer. He has a modified diet. He's not safe in the bathroom. He's starting to get depressed. All these things the students had 45 minutes to talk about. And then the last setting was in home care. The nurse seems to be coming 3 times a week, but OT has not even been prescribed. PT comes 5 times a week. The speech language pathologist has been requested because the patient is eating inappropriate food for their dysphagia diet. They now don't have their accessoride, so they can't go see the physician assistant. So we talked about all these things. And so therefore, again, these are the kinds of things that we ask the students in the breakout sessions. Then, of course, there was refreshments, because that's the most important part of any successful program is the food. And then we came back together and we had the groups report what they found. That was the job of the scribe. And if you look at our outcomes on a scale of 1 to 5, 5 being, you know, I strongly agree, everything was in the 4s. The lowest was a 4.2, but it went all the way up to a, 4.8, 4.9. So the students found this good. The impression of the program was favorable. You know, they liked the moderator, they liked the panelists, they liked the breakout sessions. So it was a pretty good first stab. When we asked them also, what is one thing you learned from attending this event, we got really, what was the point of the whole thing? Improvement of a team approach to quality care, awareness of the team functions overlapping, importance of interdisciplinary communication. You know, they really got it. They really enjoyed it. They would have liked social workers maybe, or nutritionists to be there, but they really sort of enjoyed it. And our budget was $3,000, and, you know, it really went for food and gifts for the panelists. So what were the pros? Well, certainly it was a great first stab, and we got the conversation started. The students were able to say sort of what they did. You know, we gave them like 5 minutes to read the case and sit in the room and then talk about what a PT would do, what a OT would do. But they weren't really very well prepared, but they could do it a little bit. They learned about the other people's roles also, but again, the other students weren't so well prepared. And there was nice conversation. Cons, only 10 students per program. That was a lot of effort from us for just 10 students to benefit from it. We really want to do more than that. Poor faculty prep, 30 minutes before to come in and learn about it was not enough. Poor student prep, I mean, hi, here's your case. Like, read this, soak it all in, and then please tell everybody what you might do in your role. The panel was long. The breakout sessions were too short. 45 minutes was not enough. And the group reporting at the end wasn't the greatest idea because nobody was really paying attention. So our survey was like, how'd you like the room? How'd you like the food? We didn't really ask them what we needed to ask them. So they liked it, but it wasn't a really good survey. You know, the wrap-up was relevant, the panelists were engaging, the facility was comfortable, you know, so that's all good, but that's not, you know, we could do better. So our wish list. We really want more students. We want more time for collaboration. So therefore, we're going to need a bigger space. We're going to need to do a full-day program, and we're going to need a bigger budget. better student prep and adding something in the curriculum, because the students should learn this in their curriculum. We also needed the facilitators, the faculty, to have better prep and better buy-in. So one of our needs was a more formal way to do that. And we also were thinking about more professions. The students said they wanted social workers, nutritionists. So here were our challenges, same challenges as before. We had a lot of students. We decided that we were going to go for it and do all the students in their final year. So 350 students total. Space. We needed a space that could hold these 350 students and 40 faculty. Time of year, we talked about it. We found a common free time in March where everybody could attend. That meant we had to free up all the faculty and all the students. I mean, everybody had to be free on that day. We also found a course in everybody's program. So let's say we created this fictitious patient. Where are you going to fit that patient in? And most of the programs had a class in the last semester that sort of went over cases and multi-complex kinds of patients. So it was nice that everybody had a place to put this course. In terms of the budget, the dean gave us $10,000. And then finding a topic that was relevant. I really liked that topic of QI. That was very relevant to everybody. But we found another topic. So our second annual Touro School of Health Science Interprofessional Symposium was called Destination Home. And this was interprofessional collaboration for safe and stable transitions for patients into their communities. So basically, the patient was going to be discharged home, and what was the team going to do about it? So again, we had to develop a case. Here we came up with Roberto Alvarez. I don't know why we gave him that name, but we liked it. 51-year-old male admitted to a hospital after a left CVA with a right hemiparesis. So he cannot control his right side. He cannot speak understandably. He had some other cardiac history. He lives in a walk-up, of course. Doesn't really have a lot of family support. Doesn't really work anymore. He requires a mod assist. He ambulates with a quad cane. He can feed himself with mod assist. He has frequent coughing, homonymous hemianopsia, impaired visual perception, pretty involved. So let's go back to what it is that we wanted. First of all, we wanted to include as many students as we could, so we needed that bigger space. So we looked around. I mean, we wanted a room that could have like 36 tables of 12, and we went to all these hotel ballrooms, and they were so expensive. And then, actually, I think it was Steve who came up with this. There was a temple on Long Island. It had a giant ballroom. It was not used in the middle of the week. They had all these round tables and a caterer on site, and it was perfect. It was right near the train because we have programs in all different areas of New York. So it was a perfect find. We wanted to better prepare the students and add something within the curriculum. So every program found a course, and the students learned about the patient in the course. So they learned how to treat the patient from their profession's perspective. They were totally well prepared to say what they would do with this patient. We also prepared our PowerPoint with, somebody speaking for the faculty that teach that course to say, okay, this patient case is being in your class, and this is what we want the students to be able to do with the case so that on the day they come, they can represent their profession. This was like one of the slides that we gave the faculty, so it was the pre-symposium guide to prepare the faculty. So they got something like this. So we asked all the students to get ready to treat this patient. So we as a group were sitting around and we were like, well, what is it that we want them to do? Like, they should say, for example, what are the goals of their discipline? What are the treatment plans that their discipline would do? But like, we started this conversation and the OT in the room was like, well, they should do the strengths and weaknesses. I'm like, what is the strengths and weaknesses? Like, what does that mean? Like, should they list the problems the patient is having? Like, we all have different language, like Steve said, and it was really funny to have that conversation because I thought I was sort of knowledgeable about all the other professions, but we were definitely talking different languages. But this is kind of, basically they should be prepared to represent their profession. The better faculty facilitator prep and buy-in. Okay, so each person on the committee, we had somebody from each health science program, so the speech faculty member had to go to the chair of speech, for example, and they had to get which faculty are going to be able to participate on that day. And, we made that PowerPoint to get the faculty ready. So then we thought about including more professions, and there are a lot of other people that could be. There could be the doctor, there could be the social worker, there could be the pharmacist. We could not possibly fit all these people in one room, so we had the idea, why don't we have a panel with any profession that we can't represent when we talk about treating the patient, and we'll do that first. So the tables were set up kind of like that, where you had a facilitator, which could have been faculty from any of the programs, and then 2 students from each of the programs. Sometimes it was 3, sometimes it was 1, but that was like it. So we had to make these balanced table assignments. We had these giant spreadsheets with the 350 students and the 40 faculty. The ballroom did not have sound, so we had to hire a sound person to have microphones. And then, of course, there were name tags, certificates, gifts for the panelists. We came up with a better course evaluation. So there was a lot of things to, it was a big undertaking. Made another fabulous poster by the marketing department. So Destination Home basically was the theme, and there was our agenda, where it's basically, they came in at 8:30 and we were over by about 3:15. So we had registration and then a quick welcome. And then we had a nice keynote speaker who was able to, he was somebody that worked in home care and was in charge of the education of the speech language pathologists, OTs, PTs, and nurses. So he kind of gave an interprofessional perspective. Then we had the panel, then we had some breakout groups. So here were the goals of that. After they participated, the students should be able to identify the value of interprofessional communication. That's one of the IPAC competencies. Share their discipline-specific role and the role of the other disciplines, and work in a collaborative interprofessional team. Those are some nice goals. If we could accomplish that, then you can go out into the field and practice like that. So again, we had registration and the dean said a quick welcome. Then we had a keynote. Then we had our panel. Then we had our breakout sessions. Then we came back together for like a summary. So here was our panel. We had somebody who was a nutritionist. We had a PT. Oh, so interestingly, we only had people that weren't representative of our programs, except I was able to sneak in the PT on the panel. That was my profession, because he was the keynote speaker. I wasn't going to have him get off the stage. So on the stage, we had PT, we had a doctor of osteopathic medicine, a pharmacologist, the director of Suffolk County Office for the Aging, a social worker. And here's the kind of questions that we asked them below. We said, what do you do, for patients? How do you participate in discharging a patient? What information do you need to know to do that? Who do you usually interact with? What other professions do you work with? And what are some of your challenges in your setting to be collaborative? Then, of course, we had lunch, because food is important. And then after the panel, oh, look, there is the chair of our speech program facilitating the conversation in the upper right corner. So the interprofessional team, it was like they were the discharge team. And we were like, here's the patient, and you have to discharge them. What is it that they need? Where are you going to send them? What are you going to think about? So they had to fill out this discharge worksheet. What are your concerns in terms of the home environment, the psychosocial, dietary, medical, medication? So they had to have a conversation about all of these things. And it was a very, exciting conversation. Then we had a summary in the main ballroom, and then afterwards, students handed in their course evaluations, and we gave them their certificate of, completion. So let's look at the outcomes for this event. I felt that I had the requisite academic knowledge to participate in the curricular integration component, where they were in the classroom, and they really did. They really liked the case activity in their course. It wasn't like we shoved something in and it didn't fit. They thought it was a good fit, and it was valuable. So as far as the moderator and the panelists, like a 4-2, I felt prepared to discuss the plan of care from my profession's perspective. And we did this in their class a lot, and they really felt prepared. I felt prepared to discuss the discharge plan, again, very high. I understood the role of other professionals. I was exposed to other professionals in discharge planning. I understand the value of communicating. And the breakout sessions were productive. So we asked good questions and we got very nice responses. They really were getting it. So when we asked them, what did you like best? What was the most valuable? It was all about the part where they were collaborating with the other professions. That was really exciting to them. What was the least effective? Oh my God, they really did not like that panel. They were like, oh my God, questions the panel was too long. Why do we have the speaker? Oh my God. So that was not good. It turned out that it was like, it did the opposite. We thought, like, let's have these other professions that we don't have time to fit at the table. And what we did was we showcased them. We put them on the stage and they just talk and talk and talk. So how can we change or improve this? More time in groups, more time with the case study, more breakout groups, more discussion groups. They loved that part. In summary for this one, we did spend the $10,000. The food was like $6,000, the sound was $3,500, and then we also did have to get some office supplies and some things for the speakers and things like that. So that brings us to the final thing. This was our third annual Touro School of Health Science Interprofessional Symposium. And this one we called Teamwork, Meeting the Challenge of Comprehensive Care. This program took into account all the things that we did well and all the things that we didn't do so well. And we really, I think, came up with like the perfect solution. So the breakout sessions and the teamwork seem to be the most effective for meeting those IPEC core competencies. If our goal was to really make you value what other people do and to understand how working in a team was important, the breakout sessions seem to do that the best. The panel, though informative, took the focus away from the professions present at the symposium. You know, we put other people up on the stage, which was sort of an interesting thing at the end. And the students really wanted the social workers there, especially if you were having a conversation about discharging a patient. The allotted time for collaboration, you know, should be just right. So the very first time we did 45 minutes, we didn't have enough. So because we didn't have enough for this second one that we did, we gave them like an hour and a half. But then we all like started panicking because some of the groups were done and some of the groups weren't done. So an hour seems to be about the right amount of time to have those kind of conversations. The better prepared the faculty facilitators, the better the student experience. So students sat at a table and the facilitator, which was a faculty member, was the person that had to sort of run that discussion. And the facilitators, the student experience was very facilitator dependent. If you had like a facilitator that wasn't very well prepared, they didn't think it was as good as the people who had a dynamic, well-informed facilitator. So that was an important thing for us to make sure that we had, every table had the same experience. Also, the better prepared the students were to represent their own profession, the better the student experience. If they felt like, I really know what nursing does, and I'm so proud of myself that I was able to share with everybody else what nurses do. I didn't even know that I could do that. So the better the student experience. So we also, at the beginning, before, let them sit wherever they wanted for the panel and the keynote. You know what they did? They sat with their friends at their program, so that was not interprofessional. So we decided that they should sit with their team from the beginning. They can have breakfast with their team. They can have the icebreaker with their team. This was... I don't know why this would help everybody else, but preparing their certificates by table would be better. So, let's say we had 350 students in the second one where we had it at this temple ballroom, we said, hand in your certificate, your eval, and we'll give you your certificate. So 350 students just like descended upon us. It was very poor planning. It was like madness. So we figured out that there's 12 students at a table and there is a facilitator. We're going to give them the 12 certificates so they could collect it from the student and they give out the certificate. It was much more civil. And also it was a pain for some students to travel there and there wasn't a lot of parking. So somebody came up with the last minute a bus and that was pretty good. So this year we're going to think about that. So we're ready for our third time. We had a little bit of change in the committee. We had the PA that used to be the chair, he took another position. So we had new co-chairs, which was myself, the PT chair, and a new associate dean who used to be the chair of OTA. Same person from speech, same person from OT. We had a nursing faculty member on our team, but she retired, so the chair came on our committee, and we had a different PA faculty. So we had, 2 chairs of programs, an associate dean, and then some faculty. We representation again from, all the programs. So the IPE committee was very excited to address all of these issues so that we can make a perfect day. I happened to miss a meeting, and when I came back, we made up another new patient. Like, why we couldn't use Roberto Alvarez again, I don't know. I thought he was fabulous, but I missed the meeting, and now we had an adult with autism that had been in the car accident. We wanted more breakout group and discussion and less speeches, and we wanted to optimize the day so that students could do a lot of interprofessional work, and that could be, besides just the discharge plan, what about the treatment plan? So less speeches. Instead of the keynote speaker, we were like, we want these students to know this about this adult with autism. We want them to know that autism is very prevalent, that adults with autism are especially a challenge because the population is increasing, and certainly they'll be in the healthcare system. Who can we get to do that? And the OT person knew somebody who was the head of some autistic society, and the speech person knew a great person who might talk about legal issues. And we thought about it, and we said, you know what? Why are we going to do that? Because you're going to tell them what it is we want them to tell our students. Why don't you just tell our students? So we had the people on the committee. One was Steve, and one was Dr. Alex Lopez, who's from the OT department. They have expertise in treatment of people with autism spectrum disorder, so they gave the short introduction. They said exactly what it is that we wanted to convey to the students. In addition, which was fabulous, we had an adult with autism come and speak and provide the patient's perspective. So certainly the person that we're going to make up was not this person standing in front of them, but it was, we had envisioned a male who was in his 20s. This person, this adult with autism, he came and he spoke to the students, and he just had everybody's attention. He talked about how, his dream job was to work at Staples in the computer technology department, and he did it, but here were some of the challenges. He took people's words exactly, and he wasn't really sure what they meant. It was just very inspiring. The students just all paid attention. And then we were ready to begin our sessions, and I think it just motivated them more. So our third interprofessional education symposium was called Teamwork, Meeting the Challenge of Comprehensive Care. And we found another lovely interprofessional stock photo. And there was our agenda on the other side. So better student preparation and stronger curricular integration was one of the things that we really wanted. So we identified the courses and the faculty where we could put that case. It was pretty much the same as the last time that we identified it. So it was the same courses, and I think the teachers now knew they were going to do this. So in the PT curriculum, which was my curriculum, we have a course called Complex Patient, and every week the students got a new patient case to examine, and they had to think about a treatment plan. So the School of Health Science faculty teaching those courses were given the case, and again, given the instructions. Here's the goal. You want your students to be well prepared to represent their profession at the table. We gave them a PowerPoint to provide guidance, and the committee member that represented that program was in charge of making sure that that teacher, it may have been that person themselves, or it may have been, like in my program, I didn't teach that class, but I made sure that the teacher who taught that class understood the goal. So here was our case. Our patient's name was Manny Nelson. He's a 23-year-old male with autism. Status post-motor vehicle accident because the taxi jumped the curb. Very New York case. Patient sustained a fracture of the femoral neck and had to have a total hip arthroplasty. And that is a nice thing to add to a case because you have to keep your hip in a certain position. You can't flex it more than 90 degrees. You can't adduct it past neutral. So there are precautions that you're going to have to pay attention to. He had a fracture of the right tibia requiring external fixation, so he has this big bulky thing on his leg, and a fracture of the right distal radius. he usually hangs out with his mother, who's his caregiver, and she was injured as well, and she broke her arm. The patient also had hyperacusis and tactile hypersensitivity. So that was our patient. Prior to admission, minimally verbal. So basically nonverbal, secondary to this marked apraxia, but had a few functional words like more, no, water, want. He usually uses his AAC, his augmentative assistive communication device, on the iPad. He has comprehension difficulties, relies on visual support, motor dyspraxia. He had a limited diet with many taste and texture aversions, and then we told him what his insurance coverage was. So from the perspective of speech-language pathology, there was a lot of stuff that could be done with this patient that had to be addressed by that profession's role. Certainly a lot of stuff for the occupational therapist and the physical therapist. One of the other things is that we wanted to optimize the focus of the symposium. Like we said, that panel wasn't a great idea. The collaborative group was great, so more efficient use of time. So what we had was the registration, and then we had the students sit at their tables with their team, where they ate a little continental breakfast and had an icebreaker activity. Everybody got like a card with a prompt, and they talked to the rest of the table. It had nothing to do with treating a patient. It was just, globally get to know your table. Then we had our speakers, which that included the person from speech and OT that were able to sort of talk about the day and how important this topic was, and the person with autism. Then the students went to their assigned tables, and they had an hour pretty much to think about treatment planning. So they treated this patient, and we had some forms they had to fill out. Then we had lunch. Then they got together again to think about how to discharge the patient. So we gave them a handout, and we said, okay, it's 8 days later, and this is what he looks like now. What's your plan for discharge? Then we all came back together in the main ballroom and had a summary, and they completed their course evaluations. Better faculty facilitator prep. As I said, if you're sitting at a table and you have a dud facilitator, it's going to be the worst day ever had. So we really wanted to prepare these faculty so that they knew exactly what to do, and they didn't have to do anything, they just had to follow along. So we developed a guide for facilitators. This is a very abbreviated version of it, but these are the kinds of things. So we said the students have the case. Oh, it says he's 21. I guess that's an error. He was 23. Male with autism in a car accident. You're going to worry about how to treat him, and you're going to worry about how to discharge him. What does a facilitator do? On the slides that follow, there is a breakdown of the day, hour by hour, with what happens in each time slot. And then we're going to give you a folder, and you're going to have the same exact stuff in your folder. So, for example, when we got to the part about treatment, we give you, it's not 1.5, we decided an hour was the perfect amount of time. So we said to the facilitators, here are some things that you can ask just to help you if you need some questions to guide you. Like when you're sitting with the students, they all know the case. What is your chief concern? What do you think was most important? And think about it. The PAs might be most worried about the medication or the lab values, and the OT might be worried more about, the patient's ability to do their ADLs. What are your safety concerns, et cetera, et cetera. This was just a list sort of meant to help them, but what we found was people use this list exactly. They would ask that question, then that question, then that question. So for example, at the bottom it says, what influence will the ICF model have on planning the treatment? And the ICF is the World Health Organization's International Classification of Function model, and all professions are supposed to be using that, and that's how ICD-10 codes are written. And some of the professions were like, the what? The ICF? I don't know what that is. So I wouldn't have maybe put that question in because it doesn't really apply to everybody's profession, but so for next time we might change the questions so now that we know people use exactly what you give them exactly what you want them to ask. So we're still talking to facilitators, and we're telling them, so when you're done, there's a pink piece of paper, and that's what your students are going to fill out. It had certain categories, and it sort of guided what it is we needed to know. So basically, Here is the issues and concerns record sheet. As a group, think of all the issues and concerns related to this case that you might consider in order to treat the patient. So maybe there was some sort of medical concern or some sort of social concern, and is it very important or not? So that's globally thinking about, we know this case, what are we all thinking about? What are we all worried about? And then, as a group, this was the pink piece of paper, what are the top 4 concerns, and what are you going to do about it? How are you going to treat this patient? So this form is certainly not program-specific or profession-specific, but it was a nice, it worked for everybody to fill out. You know, what's the plan, intervention, or treatment, and what is the goal of that treatment? Then, as I said, when the students got back together for the discharge part, we gave them a little piece of paper, and it says the patient has now been in the hospital for 8 days and is ready to be discharged. Plan the discharge plan. We gave them sort of the patient's status. Now the patient, I'm making this up, but let's just say it said, like, now the patient can walk with min assist, you know, and he can do this by himself, but he can't do that. So they had to think about it. And their choices of where to put the person when you discharge this person. Are you going to send him home? Are you going to send him to a skilled nursing facility? He's 23, but maybe he should go to a pediatric facility. Like, your table had to think about it. And different tables had different answers. And we had a discharge chart in the folder that the students would complete. So basically, where are you going to discharge this person and why? What is your justification for that? And look at the bottom. Are you confident that this will be supported by his insurance? Yes, no, I need to speak with the social worker. So again, they had to think about, for the discharge worksheet, how these concerns influenced your discharge planning. Like diet and nutrition concerns, they may have influenced your choice of where you wanted to send this person. So another thing was better organization. We really got it down where the facilitator had a folder with all the tools that they needed to be successful. They had the agenda for the day. They sort of had a cheat sheet of what they needed to do hour by hour. They got the icebreaker cards so that students could, you know, introduce themselves to each other. Table map is because we all began in the one big ballroom, but this temple was amazing. It had 2 rooms probably this size as well. So we took half the students into that room and half students in that room so that when you were meeting as a team, it was quieter. You know, there were 36 tables in one room, everybody chatting. So we put the table map in there. We gave them a copy of the case study. We gave them a copy of the questions they should ask. They handed out the patient case, although the students had had it in class. In the afternoon, they handed out this discharge worksheet. And then, of course, the facilitators gave out the course eval so the students could say what they thought of it. And then lastly, we had something called a closure summary. So let's say that different people decided to discharge the person to a different place. We sort of pretended that they did that, and now what does the person look like after that? So we said, like, well, if you chose to discharge him home, here's what happened. You know, and no choice was wrong. We just sort of gave them some help. And then in the student folders, they also had the agenda and their table map, so they knew where to go. Their name tag had their table on it, the case study, and the program evaluation. The budget for this one actually was a little bit less than the other one. We spent $9,000. We spent more money on food, but we spent less money on sound. We found some sound guys that were a lot less expensive. And then about $500 on supplies, but we didn't have to buy any gifts for panelists or anything like that. So what were the outcomes for this? So they were amazing. They were like almost near all 5s, meaning 5 strongly agree. So again, the first part was about the curricular integration component, what we did with them in their classroom. I felt that I really was prepared to participate and it fit into my course well. Then the interprofessional symposium component, the introduction, you know, that was when we had the faculty from speech and the faculty from OT and the dean give a little talk. That was fine. That was just the right length. It was perfect. Speaker number 2 was engaging and knowledgeable. That was the adult with autism. They really enjoyed that. And then here are really kind of the IPEC core competencies. I understood the role of other healthcare professionals in discharge planning. I understand the value of interprofessional communication. You know, those breakout sessions, one was for treatment, one was for discharge. having breakout sessions is productive and useful. I mean, it was really quite something. So then again, we asked them, what was the most valuable part of this symposium? And I could take any one of these quotes and like put it on my website or put it on a, it was perfect, everything they said. Speaking with professionals from other fields really influenced my way of thinking and approaching a treatment and discharge plan for a patient. That's all you could ask for. That's what you want from the students. Working with individuals from other disciplines and looking at the patient holistically was very valuable. Observing how it takes a team effort to address a patient's deficits and needs. I enjoyed group problem solving, learning to work together. Introduction to the multidisciplinary approach. Exposure to language. Language was very interesting because, again, not everybody speaks the same language. And priorities of other professions and disciplines. So, for example, way back when we had that patient with the broken hip and a substance abuse problem, the PTs were only worried that this person shouldn't, move out of their hip precautions. And the PAs were only worried about pain management, like totally different priorities. Very helpful and eye-opening. As a future clinician, it was great to have the opportunity to be on my own and work through a case with other professionals. I think it was very valuable. The facilitators were knowledgeable and kept the conversation going. I mean, that is great. What was the least effective? Somebody wrote food was great under what was least effective. But really, I'm telling you, so many people wrote NA. So many. That's unbelievable. Amount of time for each section was too much. We could have used more time. So you can't make everybody happy. Not having a social worker was a problem. They really wanted that social worker there. We didn't get to speak with the social worker. Everything was great. It was wonderful. Again, these are under least effective. Some of the medical terminology wasn't made as clear to the other professions like OT and speech. So maybe there was words that were, not their language. Planning from the facilitator. So this person obviously did not have the best facilitator at their table, but we're striving for that. People were quick to think that they were more important than they were. That is a thing, right? That is in real life working in a team. Some people think their role is more important, so that is very interesting. Having a case study that did not have completely equal engagement on parts of each discipline, as PA had minor contributions. So some of the PAs, though we tried to make this case have a role for everyone, the PA students didn't think that they had enough to do. So you could have included more medicine for PA students. And we just sort of had a meeting to think about next year's symposium, and the PA faculty member pointed out to us that really, there wasn't much for them to do, meaning we had to think about it. We had to give the patient like a fever so that the PAs could figure out where the infection was and how to fix it. The PAs just kind of looked at the labs and the medications, but there wasn't anything to sort of change. So what can be added or changed to improve the symposium next year? More social workers. These students really wanted social work to be there. We did not have room at the table for social work, and we also have so many programs in health science, and by the time we realized that, maybe social work should be there, it was like the week before. So what we ended up happening, which we thought was sort of realistic, was we had 3 social workers, and they had to run around to each table. And that's what it's really like in real life. You could never get the social worker to come and tell you what you need to do. They also maybe wanted psychology. Somebody's table didn't have a nursing student. Sometimes we had more of one than the other. Again, same thing. We want psych. We want social work. Social work, nutritionist, more details on the patient history, more lab values, more nutrition values, more vitals, more panels. These are the PA students talking, I think. Hour-long sessions, the amount of time could be increased, shortened breakout session times. So that's really sort of what we wanted to present. We wanted to explain what IPE is and IPP and define these core competencies for you. Some of you may have already been familiar with IPEC, some of you may not have been, but we wanted you to be thinking about it in terms of what is it that you need to do to function as a team. We talked about ASHA's IPE goals and objectives and recommendations from the 2017 CAA standards. And then also, if you do work in a educational program, you should be able to do something similar where you can create a detailed fictitious patient with the committee from your school and figure out a way that every profession can have a key role in there. And then we talked about some practical components of the model to make it successful, because you really do have to consider the facility, your human resources. It doesn't work if you don't have enough facilitators and buy-in from the facilitators. You have to think about your budget. We're so lucky our dean is so supportive, and then he's able to just give us $10,000 to do this project. Not everybody does that. Not every dean is on board. The preparation, the agenda, the logistics, where are you going to have it, when are you going to have it, communication, and evaluation. All of those things are very important. And we just had, again, as I said, our meeting for the next time. We're just fine-tuning it just a little more. We are going to use the same patient case. That was like deal breaker for me. I was not making up another case. But I think that because we're going to use the same case, all the facilitators already are somewhat familiar with it, so it's going to be better. So thank you very much for listening, and Steve and I are here if anybody has any questions for us about how to do this at your school, or, you know, your experience with it. Yes? Thank you.
Let me ask you about the second, discharge part of the phase 3. Did they get that ahead of time, or was that given to them that change?
So, meaning, no, so the only thing that they got in the classroom was, here's your patient and you're treating them. And what you're saying is they can't really think about discharging until they've read that piece of paper. So that's a good, it's almost like the mistake we made in the very first symposium where we were like, here's your patient, read it and go. But on the other hand, I feel that they really should not know everything in advance, you know, but you're right. It's.
I was wondering if they came up with, oh, because that happens, somebody gets discharged and you don't really anticipate it, but you gotta get them out, and so you have to develop something. So I was just wondering your timing. of when
Right,
that
yeah, so that was like, surprise, here's what he looks like.
This is really a dynamic, moving, growing process, which, you know, there's no one way to do this and there's no one way to measure it. And actually it is a interesting and a learning experience and somewhat fun to do these. But in terms of, in the case, we actually did throw a curve to the students at the second symposium.
Oh, yeah.
Where with Mr. Alvarez, we did not tell the students ahead of time, and a lot of their thinking was, if you, a little subtle tweak in the case was that he lived with someone.
Oh, his girlfriend,
He lived
and then
with a
we,
girlfriend and whatever.
then we-
She had it and left him.
we 86 the girlfriend. We were like, okay, now he has
So-
no family support.
But they didn't know that till the second half, and they had been thinking they're gonna rely on the girlfriend.
Right.
Who's gonna take care of him and provide feeding and shop. And as you bring up, not always do things go as planned. You have to be flexible, there's a last minute. So what we threw at them during the conference was, as a surprise, mid-conference,
Right.
his girlfriend left him.
Right.
Now you have to factor that in, which they did not know ahead of time.
Oh, and something that I didn't talk about, but at the end of the symposium, when we did have that sort of summary, and we passed the mic around, Steve passed the mic around, and we asked the students, you know, what they thought we still needed to do. We had some mistakes with the case also. Some of the things didn't work out perfectly, so we're trying to fix those for this time.
And what about compensation? Did somebody get reassigned time to help create and establish and all of that, get all this together? And then were your facilitators compensated in any way?
That's a great question. We worked like dogs on this committee because we love it. But no, it was extra work. We did not get compensated. The dean loves us, but you're right. No, it's really, it's service. It's like being on any other college-wide committee. That's really what it was.
All communities are created equal.
Well, that is true, but we love each other. No, this was a work day. This was a work day, you know, and they didn't really have a lot to do beforehand, and they're all very energized afterwards. They really do love it.
If you take a look at some of the earlier research on what makes these things successful, every avenue of support is critical. If you don't get faculty buy-in for this, if we start dealing with com time, discharge time, extra fee, if people are coming to that with that, it's another barrier that is, it makes
Right.
this more difficult. We need to really, one of the things that becomes part of this as a committee is building enthusiasm, building support. This is exciting to a point where many faculty have heard about it and have visited, and I want to do that next year. Can
Right.
I be part of that next year? And that's what you want to create.
And some people on the committee were chairs, so I could get my faculty. But like Steve is not a chair, but Steve spoke to his chair and got his chair to tell all his faculty that we are doing this and this is what we're doing. And finding that one day is a killer. Nobody wants to give up. It's killing me to give up that day. I can't afford it in my, spring curriculum, but we do it, so.
Well, those are the questions that will come up as you present something like this.
Sure.
It's inevitable somebody's going to ask about compensation. and
Right, but this really, we just asked you to go to a different place for work that day. You didn't have to work extra, so that worked out
And I
well.
hope all of this is online.
Yeah, so it was absolutely uploaded, but people said that they couldn't see it, which is a shame because it would have been nice if you had it while we were speaking about
So
it.
you
But
can certainly
we uploaded
contact
it.
us and we'll give you.
It's under the
arrange-
program planner.
As I think about it now, so many of our graduating students who went through this put it on their resumes, put it out there. And when, you're a graduate student, you're graduating, you have to build a resume, what kinds of things? Participated in an interprofessional symposium and a description, we're able to talk about. There were just so many levels to why this is successful.
I was also informed at a conference that faculty can get credit for this towards their specialist certification in physical therapy for sure. So there's probably, if you facilitated a day-long continuing education conference, there's probably something that you can claim.
Well, I've entertained the idea of developing a 12-hour certificate.
Mhm.
So that students can actually.
I don't see why
get a
not.
degree plus a certificate in IPE, IPP.
Hmm,
Develop curriculum in it.
right.
And you can't bring all of this forward, but one of the things that I found from my speech students was what they learned from other professions. You can talk about it, but to see it in action, what they realized everybody else did, and how they realized that their consideration for what the patient needs is so limited by all of these other issues that this patient has, and we can prioritize it, and people listen to it. It was, a wonderful experience, and I think it's the difference between interprofessional practice and education and just we all think we're doing something that's multidisciplinary. Bringing that over knowledge of what we're doing, the benefit, the value added, the efficiency, the limitations, you don't get it when you sit at a staff meeting and talk about your report and what you're going to do. Thank you.
We also collaborated more when all the faculty met each other. I never see the speech faculty. They're in Brooklyn, but then we were like, oh, you're going to do that with I would love to work with you on that. And we just started collaborating. It was a love fest. It was really great.
We do our meetings by video. We're in our offices at
Right.
3 campuses 40 miles away, and,
Yeah, it works well.
The other thing is we do this by video conferencing,
Okay.
most of it. So it's a challenge, but if there's a desire, and again, the support from our dean and chair people and everything else makes this happen. It's not going to happen without that buy-in from everybody, all stakeholders.
So thank you, everyone, for coming.
Thank you.